Spinal Biomechanics and Basics of Spinal Instrumentation. In this lecture, we will discuss spinal anatomy, physiology, biomechanics, balance, instrumentation, implant choice, and construct design. A thorough understanding of such principles is necessary to take full advantage of the available spinal technologies. A comprehensive review of spinal anatomy is beyond the scope of this lecture, but we will review the anatomy as it relates to spinal biomechanics, degeneration, instrumentation, and deformity correction. The spinal column is a complex multi-articular system that is responsible for transfer of forces between the upper and lower limbs. The spinal column consists of three regions: a hypermobile lordotic cervical segment supporting the head, a hypomobile kyphotic thoracic spine supported by the ribcage, and the highly mobile lordotic lumbar segment, which bears 60 to 75% of the body's weight. The spine can be divided into the following components: vertebral bodies, intervertebral discs, facet joints, the supporting ligamentous structures, and paraspinal muscles. We will discuss each in further details. The vertebral bodies are the main axial load-bearing structures of the spine and are composed of dense cortical bone peripherally and a cancellous spongy core, and cartilaginous end plates superiorly and inferiorly. The load-bearing properties of the cancellous bone are directly dependent on the bone mineral density, and as such, osteoporosis and osteopenia result in decreased load-bearing capacity. The size of the vertebral bodies increases as the spine transitions caudally, given the need for increased load-bearing. This is critical, as the more load-bearing segments of the lumbar spine can accept a larger pedicle screw diameter. The intervertebral discs are analogous to a shock absorber and act to mitigate axial loading and stabilize the spine. Each disc is composed of a hydrated core of proteoglycans in a loose collagen network called the nucleus pulposus, and a fibrocartilaginous ring called the annulus fibrosus, providing structural support. The disc has both the tension-resisting properties of a ligament and the compression-resisting properties of joint cartilage, and it serves to control the complex three-dimensional movements of the spine. The facet joints perform two basic functions: controlling the direction and amplitude of axial movement and sharing the load-bearing of the vertebral body. Similar to the vertebral body, the facet joints increase in size from rostral to caudal. The facets often carry up to 33% of the physiologic load, depending on the position. For example, in hyperlordotic positions, this can be as high as 70%. The cervical facets are coronally oriented and allow for flexion, extension, and rotation. In contrast, the sagittal orientation of the lumbar facets provides significant resistance to rotation, but not to flexion, extension, or translation. The ligaments of the spine provide passive stability, and bone-to-bone attachments provide tension and translational support. The paraspinal musculature also acts as a stabilizer and resists spinal motion. A younger spinal column is flexible with a broad range of motion, whereas an older spine becomes rigid and stiff. Each segment of the spine undergoes characteristic degenerative changes, with associated changes in the anatomy and biomechanics of the spine. As the disc dehydrates, the load-bearing properties are transferred to the end plates, leading to microfractures and subsequent fluoric changes. Degenerative changes within the disc begin with loss of proteoglycans and replacement with dry fibrotic tissue. Within the annulus, the arrangement of the fibers plays an important role in its mechanical strength. In the degenerated annulus, shear stress causes the fibers to become disorganized, which greatly alters the elasticity of the annulus. Facet hypertrophy and abnormal motion also play an important role in the degenerative cascade. With changes to the articular cartilage, the facets and the joint are at risk for damage and degeneration. As discs degenerate and lose height, greater stress is placed on the facet joints, with subsequent craniocaudal subluxation. Spinal stenosis typically results from posterior bulging of the annulus, buckling of the ligamentum flavum, or hypertrophy of the facets. Force deflection curves are commonly used when testing the biomechanical properties of the spine and spinal implants. These curves are obtained by measuring the displacement or deflection of the spine in response to an applied force. Material stiffness is the slope of the most linear aspect of the force deflection curve. A more stiff material will have a higher K value as it will take more force to deflect or deform the material. The area under the curve represents the energy being absorbed by the construct as measured in joules. Yield strength is the earliest point at which the material does not return to its original shape. Ultimate strength is the highest load achieved before failure. Understanding these material properties is important for choosing the correct implant to manage the expected demands on a particular spinal construct. Pain can often be due to compression of neural elements, but the biomechanical source pain must take into account local and global spinal alignment under both static and dynamic conditions to identify instability and determine sources of excess mechanical strain to the patient's spine. To decrease pain from an affected spinal region, a patient can minimize the excess energy transfer through activity limitations and lifestyle changes, or increase the ability of the spine to absorb energy by strengthening exercises, surgical stabilization, or both. Inadequate surgical stabilization or hardware failure can lead to failed back syndrome with persistent or worsening symptoms. Local cervical, thoracic, or lumbar films are useful for detecting focal pathologies such as spondylolisthesis, pars fractures, significant disc space collapse, or other potential causes for mechanical axial back pain. It is also important to assess global spinal alignment using long cassette films with the patient upright and while performing flexion, extension, and side bending. These films are obtained with the patient standing with the knees and hips extended and arms flexed with hands on the clavicles. This position allows for an accurate evaluation of sagittal and coronal alignment while eliminating potential compensatory mechanisms in the knees and pelvis. The films shown demonstrate the assessment of sagittal and coronal balance. In a normally balanced spine, the center of gravity of the head should rest within approximately 4 cm of the posterior superior aspect of S1. Similarly, the spinous process of C7 should lie within approximately 4 cm of the central sacral vertical line. Loss of alignment results in a pathologic moment arm. As a result, the patient's paraspinal muscles are subject to much greater strain while the patient attempts to maintain normal alignment, leading to fatigue and low back pain. 3 important pelvic parameters are shown: pelvic incidence, pelvic tilt, and sacral slope. Understanding their relationship to one another in lumbar lordosis is critical. Ideal lumbar lordosis should be within 9 degrees of the pelvic incidence. Pelvic incidence is the sum of the pelvic tilt and sacral slope. Pelvic incidence remains fixed after skeletal maturity has been attained. Individuals with positive sagittal imbalance retrovert their pelvis in an attempt to maintain sagittal alignment, thus flattening the sacral slope and increasing pelvic tilt. Measuring the sacral slope and pelvic tilt estimates the amount of pelvic compensation that a patient is using and gives a more complete picture of the severity of the spinal deformity. Stiffness is the ratio of force to deformation, but it does not reflect overall strength or energy absorbing capacity. Yield strength is the earliest point at which a material does not return to its original shape. Ultimate strength is the highest load achieved before failure. A number of commonly used materials are shown here with their associated stiffness and yield strength. A stiffer implant may in fact be weaker and more brittle, whereas a stronger implant may be more elastic but with a higher overall toughness and fatigue strength. The different materials commonly used in spinal surgery, such as stainless steel, titanium, titanium alloy, cobalt chrome, and PEEK, have different toughness and overall fatigue strength. For example, a cobalt chrome rod can have greater stiffness, but with fracture or fail area than an equivalent diameter titanium alloy. Poor bone quality can result in osteolysis around the implants, leading to pull-out, loosening, or fracture of the end plate or pedicle because of the adjacent bone being unable to withstand the stresses, so stiffer implants should be avoided. Alternative strategies include the use of larger diameter screws, bicortical purchase, shallow placement of partially threaded screws, fixation points, triangulation, or augmenting screws with PMMA. Greater construct demand may require the use of a material with increased stiffness and a higher yield point. One must take into account both the length of the construct and expected stresses. The larger the construct and the greater the degree of correction, the greater the construct demand. This is a brief summary of the key points we discussed. Determination of the biomechanical sources of pain must take into account both local and global spinal alignment, under both static and dynamic conditions. Special attention must also be paid to global balance. The patient's compensatory mechanisms, if any, must also be taken into account. Surgical planning and construct design should take into consideration the patient's bone quality as well as the appropriate implant material and size.